Well, friends, when you plan your journey, most of the time you think that the journey is going to be very smooth, but that's not always the case. And sometimes there may be upheavals, there may be roadblocks, there may be moments of joy for you, and there are moments of disappointments. So, but there is always a light at the end of the tunnel. What I'm going to show you a case which is looks very benign, and I'm sure many of you, when you see the first angiogram, may feel that why I'm showing this case. But this took 3 hours to complete this case. This this is a middle-aged lady, 68 years, diabetic hypertensive. She had undergone a previous PCI in 2008 and then again in 2019. 2019, she had a stent put somewhere in South India. Then, few months later, she came in 2020, and angiogram was done in another city, where they found that there was an intrastent restenosis in the circumflex artery. So it is presumed that she must have had undergone a stenting in 2019 in the circumflex. Now, this second place where she had gone this time in Mysore, the interventionist just did a POBA of the circumflex and left the patient. Patient was all right for 3 months, and then she returned with angina on exertion, and that's the time when she came to us. Now, this was her angiogram. The right was more or less okay. Many of you might see that this is a normal angiogram, but this is not so. She was very symptomatic, and you will have to believe me that when even going to the washroom, etc., she would become breathless and she would have some chest suffocation. There is a significant, there is a stent in the LCX right from its origin across the obtuse marginal one, and there is a sharp bend in the vessel over there, and there is a moderate degree of intrastent restenosis over there. We also, looking at this angiogram, thought that this is a very simple case and we should be able to finish it in half an hour. So the initial strategy was to balloon it with a non-compliant balloon, and if that doesn't work, then a cutting balloon would be able to do the job. And if that does not work, then we thought we should do a rotablation, and further treatment would depend upon what do we get after rotablation. So we put a NC balloon, and we were unable to open up this lesion. You can see that there is a big waste on the balloon, and after the balloon, the lesion remains as it is. So this is what you can see, that we put another balloon, 2.5 millimeter now, and you can see a tight waist on the balloon. So at this point of time, we thought that we have to move forward and we should change our strategy from balloons to stents, from balloons to rotablation. So we crossed this lesion with a rota wire. Now the next problem was that even the smallest bar of 1.25 millimeter bar would not cross this lesion. You can see that when I am trying to cross this stenosis, and particularly the bend, the lesion would get stuck up at the bend, and the guiding had a tendency to fall down. This process continued for almost about 10 minutes, and we were unsuccessful. And now you see that the tip of the wire, just keep your attention on the tip of the wire, rota wire. In the left-hand side screen, cine angiogram, the tip of the wire is in the anterior branch. And then we thought that let's do some trick here. We change the tip of the wire with a Dynaglide mode into the posterior branch. And having done that, oh my God. Once we did that, the first problem we came across was that the burr got stuck. You can see that burr is entrapped into the lesion, and this was a major problem for us. Now, we were a little taken aback, and then we tried our best to pull this burr. This is the usual practice, that you have to keep a constant traction on the burr. But we were fortunate that after giving some nitroglycerin, patient was stable. The burr came out, and along with that came out the wire. So we were successful in disengaging this burr, and then we thought we have to make a second attempt to negotiate the rota burr. So we again placed the wire rota wire and again into the anterior branch, but the burr would again not cross. So we thought that let's change the wire again into the posterior branch and try once again what happens. By changing the direction of the wire, this time the burr crossed. So a little trick that changed the bias of the guide wire allowed this burr to get down into the bend, and the ablation was successful at this time. But then the story doesn't end here. So this is the post-rota balloon was done, and you can see the balloon is still showing the same waist as what we had seen at the beginning of the year. So at this point of time, we had passed the second wire also to see that if we can crack this waist, but that would not help. So we upsized the burr to 1.5 mm burr, but that did not have much problem. So we were able to pass a 1.5 mm burr and ablate the proximal LCX and also go into the obtuse marginal branch too. After this, we put a high pressure NC balloon, and the proximal lesion gave way, and the waist disappeared. So you can now see that there are 3 wires, 2 in the posterior branch and 1 in the anterior branch. Why in the anterior branch? Because we thought we will do a burring of the rota of the anterior branch also. But before that, you can see here that once we were trying to open up the second lesion in the circumflex after the bend, the waist was still there. The proximal lesion had opened up, but the second part was still undilatable. So at that point of time, we thought we should attempt to open up the OM branch first. So we passed a rota wire there and pulled out the other. First we passed a wire, ordinary wire, and tried to open it up with a balloon. But again the same problem started. The OM branch would not yield. Then this is the stenosis persisting in the OM branch. And then we thought we should do a rota even in the obtuse marginal branch. But again the same problem. The burr would go down and it got somewhere stuck here, and it would not enter into the second branch. So while making second or third attempt, the wire broke down. And now once the wire broke down, I don't have that frame. You can see here the wire is broken, the distal tip of the wire is broken, and we were fortunate the burr went into the posterior branch, and we just noticed that the burr is moving without the wire. So, of course, the wire had broken. That was not a worry. So, we pulled out the rota without any problem. Now, you can see there is a wire tip which is broken into the anterior branch, and the burr has come out. So, we were at square one once again without having dilated the obtuse marginal posterior branch and also the obtuse marginal one. So, we wired once again all these branches once again, and I'll just go. So then what we did was that by this time 2 hours have passed on. So what next? What were the possible options? Either we abandon the procedure or use a buddy guide wire to negotiate a desk, because the drug-eluting stents were not going now. So we use a guide extension and change the guiding to AL2. But the option second and third, that is a buddy guide wire and the guide extension would not even enter into the circumflex. So we changed the guiding to a M+2 guiding catheter. And having changed the M+2, we again have to wire it, and then we were able to pass a stent down. And this led to the opening up of the first lesion, but we are still left with the second part of the stenosis, which is beyond the obtuse marginal one. So this was the result after this. We then had to deploy a second stent. But there was not much a problem in negotiating a second stent 2.5 into 28 beyond the first stent, which went on easily, and we opened up the second stent. But after, you can see that there is a significant residual stenosis still persisting over there, and repeated balloon dilatations failed to open up this. So residual stenosis persists in the distal LCX. You can see just after the obtuse marginal branch, and if you see the balloon in the right hand side, there is still a significant waste. So at this point in time, we placed firstly one buddy guide wire. That did not help, and then we put two body guide wires. You can see that there are three wires in this posterior branch and one which is a broken wire in the obtuse marginal one. And at this point of time, we continue to give high pressure and suddenly the waist disappeared. I don't think we can show you that. And finally, the stent expanded. So then we had a sigh of relief. We were able to restore a good lumen both in the proximal as well as in the second part of this Celsius OM. And this was the final result. And this was follow-up. After 4 weeks, the patient was called back to see that the obtuse marginal branch, there has been no thrombosis, etc. So that was patent. So, friends, instant restenosis is sometimes a very difficult problem to treat. We started with a moderate degree of instant restenosis and ended up in almost every complication, starting with the stuck burr, then the guide wire of the rota wire got broken up. The lesion would not yield. We had to put a buddy wire. We had to change the guiding catheter to Amplas guiding catheter, and two buddy guide wires had to be put. So many things have to be done to finally achieve this result. So I think in the end, I would like to say that when you come across this kind of problem, keep your patience, do not lose concentration, continue to work. Don't get frustrated at failures, because we had spent almost 3 hours on this patient, and continue efforts hoping for success, which means there is always a light at the end of the tunnel. Thank you very much.